Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. And as always, we're back taking your COVID questions. Today is Thursday, August 5th, 2021. And there continues to be a whole lot going on in the world of COVID, nationally, across the state, locally. We were really pleased to see the governor's announcement yesterday that masks would be required for all elementary and high school K through 12 schools across Illinois. We absolutely think that is the safest and most appropriate way to start school, and especially critical for elementary and junior high settings where kids are largely too young to be vaccinated. So where you have your COVID questions, you can put them directly into the box below on Facebook or Twitter. You can also use the hashtag AskDrArwady, and we'll spend most of the time today answering your questions directly. But first, as always, let's turn to the dashboard, chi.gov/COVID-. We're updating this Monday through Friday. Every bit of this gets updated. The summaries, the cases by zip code, the testing and positivity data, the vaccine by zip code data. So you can see we're averaging 260 cases per day right now. That does continue to rise, not in a way that is unexpected, not at a rate that is unexpected, and we are very strongly seeing this fall on folks who are unvaccinated. We are averaging 19 hospitalizations a day, also seeing some increase there. Similarly, falling on folks who are unvaccinated. I do want to note these are on different scales. So these cases here, this marks 500 and this marks 50 in terms of the scales of those two charts. We've gotten a question about that. We're averaging still just between 1 and 2 deaths a day, the best broadly that we've been throughout COVID. Our vaccinations have ticked up, which I've been pleased to see. We're back doing about 4,100 a day, and that's been holding steady. We're doing about 8,600 tests a day. That's also on the increase, which is not surprising at all. That's what we expect and what we see as cases increase and there's more folks with symptoms and more folks concerned about COVID. And we strongly, strongly encourage people, if you have symptoms that could be COVID, you have a, quote, summer cold, you feel like you have the flu, you're just not feeling well, get tested. Those home-based tests are good. Please use them. They're cheap. They're widely available. They're not necessarily reported to public health, so this is one of the places where we think a little bit differently about, there is a lot of testing that happens in the world that doesn't come through these dashboards, but we've got other ways to account for some of that. The most important thing is that you're getting tested, and that if it's positive, you're following up. If you report that, to your doctor, for example, or to the health department, we will take it from there. And then our positivity rate is at 3.5%, also still below 5% at the moment, and that's where we are. I want to just note quickly that on the vaccine front, we're at about 69% of everybody over the age of 12, about 70% over the age of 18, about 74% over the age of 65. And it's really that oldest group that remains the one that I'm the most concerned about. Where you break this down more by age, you see we've now got, almost 52%, so we've crossed that 50% mark of our adolescents, 12 to 17-year-olds have gotten at least that first dose. It just goes up from there. We're at about 60% almost of our 18 to 29-year-olds. You can see we peak in the people in their 50s and 60s, and then it starts to drop off, people in their 70s and then over 80. And I am not pleased with a 65% first dose and 59% full vaccination rate for people over 80. So especially with Delta on the increase. So, we're working the most on both ends of this spectrum, but we have room to grow across all age groups. And I'll just show you, you can look by gender, you can look by race, ethnicity, but you can also look at any of these, for example, the percent vaccinated over time or the daily average doses. So just to kind of give you a sense of this, this uses the same colors as we do across the whole dashboard. So the dark blue are the 12 to 17-year-olds. And you can see as you hover, it will pull up what in any given week was going on, what is changing. And this was when we saw the approval for those younger adolescents. But still, if you zoom in, we're doing the most vaccinations in those younger age groups, which is good because it's where we have the most room to grow. So I encourage you to explore this and explore the zip code page. I also just wanted to very quickly highlight where we are as a city. Sorry. Slideshow from beginning. Okay. So again, these are the same metrics that we've been using all along, more than a year, and you can see that our case rate has moved into that substantial transmission, which we used to call moderate, but we're calling it substantial because that's the word CDC uses. That's exactly, these are the same cutoffs as what CDC uses to define substantial transmission or high transmission. And our test positivity remains in that lower transmission risk range. We've got about 158 people hospitalized across Chicago with COVID in non-ICU beds and another 46 in ICU beds. Those numbers are also increasing, but in a way that is again, very, very heavily among those who are unvaccinated. And I told you we would create a Chicago version of that graph that we showed last week, and I think on Tuesday as well. So in Chicago, this is just highlighting for Chicago residents of everybody who's been vaccinated here in green. The red represents breakthrough cases, and then the yellow represents breakthrough deaths. And so this is the 99.9% have not developed the breakthrough case of COVID, and continuing to see the increase from there. We're 99.9%, 99% have not been hospitalized, 99.999% have not died, and we continue to follow that for cases and vaccinations. I also, this is a good news thing that normally I put at the end, but I did just want to go ahead and call it out so I didn't forget. So there are 5 weeks that are happening right now for folks who may still be out of a job as a result of COVID or just be looking for a new area of employment. There's a big push that's called Hire Chicago that just started this week and is running through early September. And each week there are interviews and free job prep workshops, and then there are the ability to actually interview for jobs with a lot of different types of employers. So this first week is a focus on manufacturing. The week of August 9th is hospitality, tourism, and food service. The next week is transportation, distribution, and logistics. The next week is healthcare, and the last week, the week of August 30th, is technology. So go to hirechicago2021.org if you or anybody you know is interested in jobs in these really quickly growing industries here in Chicago, and you want to learn more about the space and make some connections. Really hoping to get a lot of people working in these areas. And you can see it's sponsored by the Chicago Cook Workforce Partnership, World Business Chicago, as well as the city. So just wanted to share that. And with that, we will turn to your questions. Okay. Lots of things coming in already. All right, have I heard of the Delta, this is Michelle. Have I heard of the Delta Plus variant? Is it more infectious? Are we seeing any of these cases in the Midwest? Similarly, we've got PK. Can I address the Lambda variant? Is it in Chicago? Okay, so we talked a little bit about variants on Tuesday, and I'm always happy to take questions about variants. As a reminder, there are variants of interest, which are the lowest level. There's variants of concern, and then there's variants of high consequence. We've never had a variant yet that has been considered a variant of high consequence. If we did, that would be a very big deal. It would mean that we would probably need to be doing another round of vaccinations or making major changes, but we've not seen anything that the WHO, the CDC, anybody has labeled this variant of high consequence. We do have some of these variants of concern. The one that has been getting the most attention right now, of course, is the Delta variant. And so this Delta Plus variant, quote unquote, that Michelle is asking about is actually sort of a subtype, if you will, of the Delta variant. And it's not really called Delta Plus. That's what the media has been using the term Delta Plus. All it is, it's the Delta variant, but we're also seeing one of the mutations that we had seen earlier in actually the beta variant of concern that's also in there. So it's more formally known as AY.1. There have been a handful of cases, but not even 1% of cases, either here in the Midwest area or in the US, have been identified as that AY.1. And to sort of the larger point, even within Delta, right? The formal name for Delta is B.1.617.2. It's hard for people to remember that. But always when this is being followed, you can see these sort of smaller changes that remain the Delta variant that is named the variant of concern, but there can be some slight changes. And so trust me, the scientists absolutely track those sub-pieces within it. So there's AY.1, which is the one that some people are labeling this Delta plus. There's an AY.2, there's an AY.3. All of them have been shown to have the same amount of what's called neutralizing antibodies. Basically, the vaccine continues to work effectively. We've not seen anything at this point with any of these variants that makes it be acting significantly differently than Delta. And importantly, it's not out-competing the original Delta strain. So among those three subtypes, Delta is absolutely the dominant. We're seeing exactly the same thing happen in the US that we saw happen in the UK, that we saw happen in India, where there is a big surge when Delta comes because it is more contagious. It outcompetes whatever other variants are there. And so in early July, we were already at a point where more than 80% of cases across the US and actually here in the Midwest area already were that Delta variant. But if you break it down a little bit to this point of Delta and Delta plus and A1, technically 72% of them were the original Delta, and then there's like another 10% that were this Delta AY.3. But in terms of how they're behaving, there's not been anything that's more concerning. And in fact, the AY.3, which is the one that the subtype that there's more of, those numbers are actually going down while the original, if you will, Delta variant is stronger and outcompeting. So all I would say is that whether it's Delta, we talked a little bit about Lambda the last time, you're going to keep hearing about variants. Lambda has not been labeled a variant of concern. Where there is a variant of, if there is ever a variant of high consequence, you will not miss that news. That will be a very big deal. It would probably mark significant changes to what we needed to do at the societal level to potentially control the virus. Otherwise, these variants of concern show up for sure in the way Alpha showed up, in the way Delta showed up. They're more contagious. They could make people sicker. They could make the vaccine less effective. And so it's part of the reason that we've made this recommendation for the moment for people to have their masks back on in indoor public settings, even if they're vaccinated, is just because we're getting through the surge of Delta right now. But it's already here to that point. Probably more than 90% at this point are already the Delta variant. So it's not that we're waiting for it to arrive. It is very much here, but it's not behaving in any way differently than we would expect. Okay. We've got Matt via email. mRNA technology safety is based on past usages. I think asking, can we talk about mRNA technologies? Oh, okay. Can we talk about mRNA technology safety based on past usages? Matt says, I say this because I have seen that mRNA technology was used in cancer advancements before. Why were those not taken or gone past the clinical stage? Did the cure not work? Were there issues with the technology? If the mRNA has never had issues, why didn't the cure work? Basically, can you just talk some more about the history of mRNA vaccines? Yeah, Matt, thanks for those questions. They're really good. And they raise for me a similar range of questions that we've gotten and that I continue to hear on social media, is just that there are still a lot of people, I think, who don't trust the science behind how these vaccines came to be. How were they developed so quickly? How can we trust that something that seems so new has had all the appropriate testing? And so I would point you, there's actually a really, really nice journal article in Nature. Nature Drug Reviews specifically. It's from before COVID. It's actually from January of 2018, but it's this big summary of what scientists were already doing related to mRNA vaccines. And the title of it is literally mRNA Vaccines, A New Era in Vaccinology, which means testing vaccines. And I'm just going to read you a couple of sentences from this. And then for those of you who have more science questions, I'd refer you to this. mRNA vaccines represent a promising alternative to conventional vaccine approaches because of their high potency, meaning they work really well, capacity for rapid development, and potential for low-cost manufacture and safe administration. However, their application, meaning our ability to use them, has until recently been restricted by the instability and inefficient in vivo, meaning in live individuals, delivery of mRNA. What that's basically saying is they were able to show in the lab and in some animal models, but they were having a lot of trouble stabilizing the mRNA molecules. So there's been work not just to develop the mRNA technology, but actually one of the most important things was the work to figure out how to stabilize these really fragile messages in little droplets of fat, for example, lipids, so that they actually can last long enough to be able to, I mean, they don't need to last that long, but they need to last long enough to be able to be injected, and they never get incorporated into the DNA in any way, but they teach your cells to make the proteins to fight off COVID. And so if you read these articles and others, what you see is that the very earliest mRNA vaccine reports that were used in mice, for example, go all the way back to 1990. It's been, what is that, 20, 30 years that this field developed. And there have been, some of the cancer spaces have been some of the work that I think has been the most promising, but there's been work that developed around Zika and Ebola and other diseases, but it took a very large influx of funding and urgency, frankly, to bring these smaller studies to scale for the COVID vaccine. And so the difference really was that the government decided we're going to invest billions of dollars in making sure that all of this science gets focused on, gets done, and we're going to focus on figuring out the manufacturing and the stabilization process while doing all of the safety work. And so I think the fact that these vaccines have performed so incredibly well for COVID is not a surprise to the scientists who've been working in this space for a long time. Moderna, for example, has been around for 10 years, right, doing nothing but working on creating mRNA. Pfizer BioNTech, which is the German company that is aligned with Pfizer, was doing mRNA vaccine work far before this, but more on an experimental scale. And frankly, for things like an Ebola vaccine, there was not the financial incentive in some ways for the companies to take the risk. It's extremely expensive to do very large scale trials, and they're worried that if not a lot of people are going to want to purchase this vaccine, not a lot of governments are going to want to buy it, they don't always make the decision to do some of those riskier studies. But because governments around the world basically said to scientists, we'll front the cost of further development, not all the vaccines made it across the finish line, right? Like all along, Merck had done a number of vaccines that really just didn't pan out in terms of an efficacy standpoint. But Merck itself didn't lose a lot of money over that. The various governments around the world, right, were the ones who really adopted it. And so I am sure we are going to see mRNA technology for other infectious diseases, and I think also all of this work has moved the needle on trying to think about some of the, quote-unquote cancer vaccine or cancer treatments using some of this same technology. So I hope that helps maybe reassure a little bit. If you're thinking this is brand new, we can maybe post just a link to this article if you're interested in some more of the science, but there's 222 individual studies that are listed in this one one review article from early 2018, and there's been obviously many, many more since then. So the newer vaccines and really the success of safe and effective vaccine is built on decades of work that came before. Okay. So we've got some more questions. Dan Sullivan on Twitter is saying, I've heard the heavy lifting on the Moderna vaccine was done over a weekend in January 2020. Why can't Moderna and Pfizer essentially reprint a vaccine using the Delta spike protein and immediately start distributing it? Flu vaccines are brought out new every year. Yeah, thanks for that, Dan. That's an interesting sort of framing and good set of questions. So first of all, the heavy lifting on the Moderna vaccine, quote unquote, you heard me say Moderna was working on this for about a decade before that. Certainly, in terms of that work in January 2020 was pivoting a lot of the work that they were already doing around other diseases and pivoted that toward COVID in the same way that laboratories all over the world did. But that was built on top of, decades, honestly, of research. And so this question of why can't they essentially reprint a vaccine using the Delta spike program, and also that flu vaccines are brought out new every year. So flu vaccines are brought out new every year because flu mutates ridiculously more than COVID does. Like, ridiculously more. There are whole strains of flu. There's influenza A, there's influenza B. You hear about H1N1, you hear about, there's the world of variability in influenza is huge and varied. So much more variable, so many more variants, so much more mutation than anything that we have seen happen for COVID or any of the coronaviruses. And so the reason we make a flu vaccine every year is because every single year the scientists are actually looking at which strains, which variants, if you will, of flu are the most dominant. So they're kind of doing what you're suggesting. They're saying, the equivalent of the Delta strain of the flu vaccine, although there aren't Delta strains of the flu vaccine, but you get the idea. Like whatever the strain of the flu vaccine is that is the most prominent, you want to make sure the vaccine that you're going to be giving out for the next flu season covers that variant. But because it mutates so much, you can't cover all of the types of variants, if you will. And that's part of why the flu vaccine is also not 100% protective. And actually, within public health every year, we talk about how good the match is. How well were we able to take, because the summer and winter are in opposite hemispheres, when we're making the flu vaccine for the northern hemisphere's winter, we're looking at what flu viruses are circulating the 6 months before in the southern hemisphere's winter, if that makes sense, and vice versa. And so there is a continuous production of flu vaccines based on that, but it still takes months and months to produce those. And so in the case of the COVID and even the Delta, we've not had at this point evidence that the vaccines are significantly losing efficacy. We certainly have seen a little bit of decrease there, but some of that decrease is more about levels of antibody than it is actual decrease in protection. And antibodies are not the only way that we measure protection from a vaccine. Antibodies are like what your body has right on hand to be able to fight off an infection. But your immune system is complicated. There's B cells, there's T cells, that if you're exposed, not just to COVID, but to some pathogen, some germ, and you've seen it before, or you've been vaccinated against it before, those B cells and T cells can do their work to sort of churn up the immune system again and produce more antibodies. And so it's not just about what you have at that moment, it's about some of these sort of longer term lessons that your immune system learns. And so as a reminder, we've been studying in a large scale way in humans these vaccines for more than a year at this point. We don't have concerns at all, to be clear, about sort of long-term side effects. always in vaccines where we've seen long-term side effects, they come within the first 6 weeks. But obviously at this level, you want to follow and look for that, and we continue to do that. Really, the bigger questions, at least for me, where I and everybody are interested in having these studies continue, which they are for years, is measuring things like the level of antibodies in people after a year, after 2 years, after 3 years, comparing to see what breakthrough infections look like, right? This is why CDPH and all over the country, we're putting such a lot of resources into investigating every case that we identify as a potential breakthrough case, or every case of a reinfection, because maybe it's a variant, but also what are we learning about waning immunity? But the news really is good. And so I do think at some point we may see a booster recommendation, but we're more likely to see that, I think, we'll see, right? We're more likely to see that, I think, for particular populations, as we do for other diseases, even flu. There are stronger versions of the flu vaccine, for example, that in certain years are kind of designed for people over 65. Might there be a recommendation for a booster shot at some point for people over a given age, or people with immune conditions? I think is probably the most likely. We may, immune compromising conditions, only certain ones. Might we see that at some point? We've shared some data even with you on Facebook here about some of what we're learning there, possibly people in nursing homes. And we're part of those studies. We're contributing information about what we're seeing and learning. But the recommendation for not needing a booster dose at this point is kind of to that point. The WHO also, I don't know if you saw this, but just in the last day or two, they really released an ask that the wealthy countries of the world not do booster vaccines until at least 10% of the world's population has gotten at least a first dose of vaccine. The things we have to worry about the most in a long-term global perspective from COVID, obviously at a Chicago level, I'm very worried about people who have not yet gotten vaccinated, but at a global level where so much of the world still does not have access to vaccines, those are the settings that we're more likely to see new variants emerge, and getting the world vaccinated is just as critical as getting sort of the US vaccinated. And we're not going to be able to sort of booster our way out of this. We need to sort of think about some of this vaccine equity. And so, they really asked, which doesn't mean there might not be a recommendation for a certain group, but generally to put that focus on getting at least 10% of the world vaccinated. You look at India. India got hit incredibly hard with the Delta variant. And that's because there was almost no vaccine on the ground. Still, only I think 7% of India is fully vaccinated against COVID. That is dangerous, particularly with these new variants emerging. We are lucky to be sitting in a country where we have vaccines sitting on shelves unused. But it is, in terms of my worry, yes, of course, what I have the most control over is what we can do in Chicago, and that's why we're working so hard to continue to encourage folks, especially with the Delta surge. Like, now's the time if you haven't done it. But at that larger level, there's that too. So the pharmaceutical companies are doing all that work. They are very ready to go when and if there is need for a booster, but we've not seen anything that says a Delta, for example, that would be a requirement. And as we continue to learn about this, it's possible that recommendation may come, but it's not there now. I have not gotten a booster, to be perfectly clear. I have not recommended it for a single person, and it's something we may need in the future. We may not, but it's not like flu. Good question. All right. Aaron Hoffman from Facebook. Do you recommend getting a COVID test for folks who went to Lollapalooza? When would be the best time to get tested? Okay, good question, Aaron. So obviously we're doing a lot of follow-up. Just as we do after large gatherings, we continue to investigate every single case of COVID that gets diagnosed in the city of Chicago. Just as a quick aside, please answer your phone if the Chicago Department of Public Health calls you or Contact Tracer calls you. It's from 312-742-6843. It actually shows up as Chicago Contact Tracer, I believe, but it depends depends on if you're on a cell phone, etc. 312-742-6843. You can put that in your phone so it's not an unknown number, although we do try to leave messages and other things. But we will continue to investigate. So really our recommendation around Lollapalooza, obviously, we're especially interested in this because it was a highly vaccinated event. Truly, more than 90% of the folks in there vaccinated, the rest tested. Our concern is much less about the actual event than it is some of the indoor gatherings that may have happened around it, but for sure, we want to explore this. Anybody who has any symptoms that might be COVID, whether you went to Lolla or not, okay, to be clear, anybody in Chicago, if you've got a quote summer cold, if you're like, I feel like I have the flu, that's weird, I'm just not feeling well, please, 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 please take a COVID test. Whether you're vaccinated, whether you're not, you can take the ones that are over the counter, I'm fine with that, but take a test. I've got tests sitting, you can buy these 2-packs for about $23 or $24 from Walmart, from Walgreens, from CVS, from other merchants. You can have them delivered from those same folks via DoorDash. You don't even have to leave your home. I have those, and that's a 2-pack that you get for that amount. It's a self-test. You get the result in about 15 minutes, and I keep those at home. And I would encourage folks to have those at home so that if you've got a symptom of any kind, just take a test, and then you can feel confident that it's not COVID. So first, anybody who has symptoms, if they attended Lolla, but even if they didn't attend Lolla, take a test. Other than that, if people are unvaccinated, right, we said that would also be, in terms of the gathering, would make that recommendation. And we're at a point, we are right now, it was a week ago that first day happened. So, it was a 4-day event. Again, it's not just the event, it's the things around it. So we are starting to be in the time frame where if you're curious, if you're wanting to get a test, etc., you can go ahead and do that. And we will continue to do all of the extra surveillance and follow-up and work, the additional, the regular things that we do for every case, some additional follow-up, of course, related to the large gatherings. And just to kind of give you a little sense of this, it's not just Lolla, right? We do this sort of comprehensive look at large gatherings and at settings across Chicago. So like this coming weekend, for example, is Market Days, and that is another large outdoor event. This one happens to be in the public way. It's sort of more of a street festival, but just like our vaccine ambassadors were on site at Lollapalooza, and they're talking to people and, are you vaccinated? Are you tested? There's testing available. We're doing some extra testing to understand risk. We're signing folks up for vaccine. We're giving out proud to be vaccinated stickers, and we've worked with the organizers, the business group, particularly for the bars and the other sort of party type settings that are around some of these events, who have largely said we'll look for vaccination or testing results to be able to come into these indoor spaces. And it's that kind of work that again helps keep the risk low for folks. If folks come in and they don't bring a proof of vaccination, we'll offer them some testing available on the spot if they're interested. Again, the indoor is of more concern, and just get vaccinated. Like if everybody's vaccinated and you come to these settings, really what we know about indoor events continues to be that risk remains low, and we'll be exploring some more. And so not just Market Days, but looking ahead to some of the parades, et cetera, we're there to get the information out about vaccine, get folks signed up, and make sure that where there are things that may need additional attention in terms of us learning about risk for COVID, needing to change recommendations, we want to be on site. And we've got a plan for that goes far beyond Lolla, although that has been so much of the media attention. Spider on Twitter says, "Hi, I'm scared to give my child the second shot due to the risk of myocarditis. Why doesn't the CDC recommend one shot to limit the risk of issues? Unfortunately, saying the cases are mild does not make me feel comfortable." Okay, good question, Spider. So for folks who maybe haven't been following this so closely, myocarditis literally means some inflammation, of the heart, potentially of the heart muscle. And myocarditis is is not common. It is a very rare condition at baseline. It is one that we have seen in children who have been diagnosed with COVID, to be clear. It's also one of the things that they've been concerned about, where they've looked at college athletes who have gotten COVID, not COVID vaccine, who have gotten COVID. Some of the best studies of that, where they went and actually did ultrasounds of the hearts of these like elite athletes. There was a big study that found like more than 2% of them, like 1 in 50 of these athletes that got COVID actually had a form of this very mild myocarditis after COVID. And it's one of the reasons why we've been really aggressive around recommending COVID vaccination for athletes, for college and those settings, because the risk is much higher for this if people get COVID. However, what was also seen, again, very low numbers, but there was a slightly increased risk after the vaccine for some of the, it was a little bit higher in men, in sort of teenage boys than it was in teenage girls. It was also a little more likely after the second dose, to the Spider's question here, than it was after the first dose. But it was still like very, very low. I don't have the exact numbers in front of me, but I'll bring them next time we're up, so we can, because it's been a little while since we talked about these exact numbers, but much, much lower than the risk of this with actually getting COVID. And then importantly, to this thing of, I understand saying the cases are mild doesn't make you feel comfortable, but it's not just that they were mild, it's that people have recovered entirely. And so we see, as people have a robust immune response, part of that robust immune response sometimes can be temporary sort of revving up. And there's been seen a little bit of this. And that's part of why as the CDC, as the FDA are looking at the approval for some of these younger children, they've asked for some of the numbers to get expanded so that we can make sure there's even some bigger sample sizes. Because we want to be really confident that when we're saying these vaccines are safe and recommended for children, that they are. And so all of the recommendations from every public health agency, from all the pediatrics agencies, like you look up the group, definitely say you should, for children, absolutely, the recommendation is to get both doses of the vaccine. The only recommendation that changed was that if a child or anybody developed the myocarditis or the pericarditis, again, mild resolves after a first dose, they did recommend just not giving the second dose in that setting. But that's different than my child got the first dose and didn't get the second. So what I have recommended to my own family, to patients, to folks who have asked, is absolutely to get those second doses because we want to protect kids. If your biggest concern is your child getting myocarditis, then getting the vaccine is actually important, because the risk of them getting myocarditis from COVID is so much higher. So really good question. If you've got more about that, go ahead and send it in. And on Tuesday, maybe next time we're back, I'll bring a little bit of those numbers and we can put it in some context with Chicago numbers here too, so you have a sense. All right, we are just about at time. Maybe I'll just take quickly. Justin says, the news says you were turned away from Lala because you didn't have proof of vaccination. What's the deal? Oh my goodness, you guys. The amount of craziness around like Lala and me is just a little bit crazy. Let me be very clear. I am fully vaccinated. I have full proof of vaccination. One of my goals of going to Lala, which I did multiple times, was to actually know what the screening process was. Not as Dr. Arwady with an entourage where, you're going to get a song and dance potentially, but just as all the people are who are coming through. So yes, I put on a hat. Yes, I put on sunglasses. Yes, I put on a mask and went through by myself. And the point is, I was bringing different kinds of my proof of vaccination because I wanted to see what the folks would do with it. I was really pleased that, like, for example, you know, I've got my CDC card, but I also brought a printout of what's called my iCare registry, which is the formal state registry, but it's got not just my COVID, it's got my tetanus, it's got my HPV vaccines, like all the vaccination records are in there. And I was really curious, right? Like, is this a sort of just wave and you're through, or are people actually looking at it? And I was very reassured that people were, you know, they don't know who I am, and not just me, but the other folks in line, they're looking, you know, I got to see the COVID. Where are the dates? Where is this from? Has it been the right amount of time? If it was tests, you know, what is the time frame on tests? And we did have a couple of our CDPH folks and some of the core that does the vaccine ambassador work. A couple of them actually the first day did show up without, they forgot their proof of vaccination. They got turned away. That's good, right? They had to go get their proof of vaccination to come back and or bring a negative test. So it was not that I got turned away because I'm not vaccinated. It was that I went multiple times because I knew I was going to be answering questions about this, and I wanted to see with my own eyes what was happening. It's also why CDPH had folks inside the gates there, you know, doing some follow-up checking around what were we seeing for vaccination rates. So that's the deal. Apparently this is now a national Fox News story, and I will just say that there are more interesting things to talk about, in my opinion. But, you know, I guess I'll answer questions where the world continues to be interested or try to twist information. So that's where we are, and I hope that helps clear it up. I was actually vaccinated on television, if anybody would like to go back and watch the proof of that. But clearly I am vaccinated. Thank you all very much for joining. Thank you for those of you who are sending in questions. Please keep sending them in. And like I said, where we get something that I think that we're seeing repeated, we'll bring some Chicago-specific data. My only goal is to help answer your questions, help answer questions for your friends and family, or for anybody who hasn't decided to get vaccinated. No shame if you've not gotten vaccinated yet, but like, now's the time, really, because almost all of our hospitalizations and deaths, like almost all of them, are now largely avoidable. And I just don't want us to I don't like to unnecessarily see people suffer, right? I'm a doctor. And getting vaccinated is the way to help us all get past this, but it's also the way to help keep your friends and family and neighborhood and whatever you care about safe. So thanks again. We will be back next week answering more of your questions. In the meantime, you can keep using the hashtag AskDrRWD, and we'll keep putting information up. Thanks again.